Hello. In this section, I will talk about perioperative blood management. Now, techniques and strategies for perioperative blood management spans throughout the perioperative period, right from pre-anesthetic checkup to the discharge of the patient. Now, for example, if I receive a patient for some elective surgery in which we are expecting a huge blood loss or we are expecting a considerable blood loss and the patient is borderline anemic, now we have ample time. It's an elective surgery to optimize the patient and to build up his hemoglobin and then take the patient for surgery to minimize the risk of intra-op transfusion and minimize the risk of intra-op bleeding and overall improve the outcome in the patient. So the strategies for perioperative blood management can be divided into three broad divisions: strategies which we implement in pre-op period, strategies which we implement in intra-op, and strategies which we implement in post-op period. And studies have shown that if we implement all the strategies throughout the perioperative period, what has been suggested, then it improves overall outcome and also is cost saving for the patient, right? So let us start our discussion with the preoperative strategies. Now, preoperative strategies, as I said, starts from pre-anesthetic evaluation. Now, pre-anesthetic consultation, when the patient comes for pre-anesthetic consultation, now that is a wonderful period when we assess our patient and we assess our patient for the risk of intra-op bleeding and we intervene with proper intervention to minimize those risks. So we in this pre-anesthetic checkup, we identify certain disorders which would increase the risk of bleeding, which would cause intra-op and post-op anemia in the patient, which would cause the requirement of blood transfusion in the patient. We identify those disorders and manage it. Then in pre-anesthetic evaluation, we also evaluate the surgery for which the patient is posted for and what is the expected blood loss and how much preparation we have to keep for the patient, and also that gives us a good time period for managing the medications of the patient like anticoagulants and antiplatelets, which the drugs which can increase the intra-op bleeding, what are the recommendation and when do we need to stop them, so we have ample time period to stop them, right? So pre-operative strategies, the pre-anesthetic consultation. The pre-anesthetic consultation provides an opportunity to assess and address risk of bleeding, risk for bleeding, and evaluate possible intervention to minimize those risks, and requirement of blood transfusion. So it gives us the time to identify certain disorders like your anemia, thrombocytopenia, coagulation disorder, right? Then liver disorders. Then surgical procedure, we can evaluate the surgical procedure for which the patient is posted for, and also it gives us ample time for perioperative medication management for the drugs which can increase the risk of bleeding in intra-op period. Now, if my patient is posted for elective surgery and patient has certain disorder, the patient has certain reversible disorder which can increase the risk of bleeding, which can increase the risk of patient getting a blood transfusion, we can optimize that patient. Since it's a reversible disorder which we can optimize the patient and then take the patient for surgery for giving us a better outcome in the patient. So if a patient has anemia or a reversible coagulopathy, right? So what we can do, we can postpone the patient for a reasonable time period and then take up the patient for surgery to give us a better outcome. So in pre-anesthetic consultation, we have the window period for all those plannings as well. Now, in pre-anesthetic consultation, we also see certain investigations of the patient, which would help us in planning for the perioperative blood management. So, first investigation, which is very helpful, is complete blood count of the patient. So, any surgery in which we are expecting a moderate to a major blood loss, we get a complete blood count done, right? So, complete blood count, complete blood count, or CBC, right? Now, if we are expecting a blood loss, of more than 500 ml, then definitely we will get a CBC done. And if the surgery is a major surgery, then if a patient has anemia, now if patient has a pre-op anemia, pre-operative anemia, right? Now, we need to evaluate the reason of the patient, why the patient has preoperative anemia, and we can evaluate and manage and optimize the patient. Optimize the patient before surgery, and then take the patient for surgery. This would decrease the risk of the blood transfusion in the patient. Now, ideally, the CBC should be done 4 weeks prior to surgery to give us ample time to manage the conditions. So, ideally, CBC should be done 4 weeks prior. 4 weeks prior planned surgery. In which we are expecting a loss, right? Now, if it's a very minor surgery like the dental procedure, or very minor surgery which is not, we are not expecting any blood loss, the number of time CBC is also not done, right, at many centers. But most of the center, before any elective surgery, get a CBC of the patient done. Even before the emergency surgery, we get a quick blood report of the patient to give us an idea how to manage our patient. Now, screening test for bleeding disorders, routinely it is not done. CBC is kind investigation which is routinely done, but screening for bleeding disorders are routinely not done. But if during history my patient has certain kind of bleeding history or familial history of bleeding, or patient is on anticoagulants, etc., then we can get a coagulation profile of the patient done. So, screening tests for bleeding disorder, right, is not routinely done, but if patient has any family or personal history of bleeding, appropriate screening test can be done. Appropriate screening should be obtained. Okay. Now, if a patient is taking anticoagulants, a lot of patient you will get is on anticoagulants. So, if patient is on anticoagulants, okay, so what do? They already have a coagulation profile with them. We should screen those coagulation profiles. So, lab reports should be reviewed. So, if a patient is on warfarin, then PT-INR should be reviewed, and it should be reviewed after stopping the warfarin for a certain time period as well, which we will discuss. Then, if a patient is on oral anticoagulants like dabigatran, etc., then we need to review the creatinine of the patient. Why? Because depending upon the renal function test, for that time period we have to stop the dabigatran before the surgery. Like normal patient, we stop 24 hours prior to surgery, but in a patient with renal dysfunction, we need a longer duration for it to get eliminated. So 48 hours before we have to stop. So we get a creatinine done. Then we get a typing and cross-matching of the patient's blood done, right? Typing and cross-matching. Right? Done. So, these are the investigations which would help us in perioperative blood management. Now, if in the investigation in pre-anesthetic checkup, my patient is diagnosed with anemia and iron deficiency. How do we manage? So treatment of anemia and iron deficiency. Now remember, iron deficiency is iron deficiency, and the exaggerated form of iron deficiency is anemia. And blood transfusion is not treatment of iron deficiency, it is treatment of anemia. So we have to replete the iron store of the patient, and depending upon the urgency of the surgery, the type of surgery, we have to plan our intervention. So as anemia is one of the most highly prevalent, let's say, conditions which increases the risk of morbidity and mortality in the patient, we have to assess our patient for anemia. So anemia is a highly prevalent risk factor for morbidity and mortality. Morbidity and mortality. Mortality in surgical patient. And it is a independent risk factor to increase the requirement of blood transfusion, as it seems. So depending upon the cause of anemia and degree of anemia, then depending upon the urgency of procedure, and depending upon the expected blood loss in the procedure, right? We plan our management. Okay. If the surgery is urgent, then definitely we don't have ample time to replete the iron store, right? We have to plan for the transfusion and we have to take the patient. So how do we treat the iron deficiency or iron deficiency anemia? So iron deficiency or iron deficiency anemia, how do we manage? So iron deficiency and iron deficiency anemia. So as I said, that major surgery can be postponed if it is elective, if the patient has anemia, and we should manage the anemia and then take the patient for surgery. But urgent surgery cannot be postponed. Now, management of anemia, and that is iron deficiency anemia, is to replete the iron store of the patient. And ample time should be given to the patient for the repletion of their iron store. So, transfusion is not the treatment of iron deficiency anemia. It is repletion of the iron store. What is the treatment? So, how can we treat the iron deficiency anemia? Number one, we can go for oral supplementation of iron. Now, this will definitely take time, and it takes 4 to 6 weeks for the iron store to be 4 to 6 weeks for the iron store. I mean, sorry, not 4 to 6 weeks, several months actually. Several months for the iron store to get repleted, right? And if we are using IV intravenous iron, then it takes 4 to 6 weeks to get repleted. So we have to wait for 4 to 6 weeks. So if a patient, the surgery is semi-urgent kind, then we can use IV iron. And if patient cannot, I mean, oral iron cannot be absorbed properly, then also we can go for IV iron, right? Now, apart from that, there are several other drugs which we can use. We can use erythropoietin, right? Erythropoietin, there is specific indication where we use erythropoietin. So use of erythropoietin. Okay. Now, erythropoietin, what does it do? It stimulates the RBC production. So, erythropoietin stimulates RBC production, and it will this increased RBC production would increase the hemoglobin level. So, when we are giving erythropoietin, it should also be supplemented with iron. So, supplementation with iron should be always included. So what is the dose of erythropoietin? Dose of erythropoietin. Now, it should be given for the optimal benefit, it should be given 3 weeks before the procedure. So it should be given 3 weeks before an elective procedure. An elective procedure, and the dose is 40,000 units, right? Or we can go for 300 to 600 units per kg of erythropoietin alpha, right? Now, what are the adverse effects when we are giving erythropoietin, which we have to look for? Thromboembolism can happen, hypertension can happen. So we have to look for we have to monitor the patient for thromboembolism. So if patient is at a higher risk of thromboembolism, I would avoid it. Or we have to monitor the patient for hypertension. Okay. Now, where are erythropoietin indicated? So for patient with anemia of chronic disease or anemia of inflammation, now their bone marrow may be suppressed and erythropoietin may be very helpful. If they are scheduled for some major non-cardiac surgical procedure with expected blood loss of more than 500 ml and HB is less than 12 gram per deciliter, then clinical judgments, and for patient with between 12 to 13 gram per deciliter, we can go for erythropoietin. So if patient with a chronic disease or anemia of inflammation or is scheduled for major surgery and HB is less than 12, then erythropoietin for sure we should give, and between 12 to 13 it's our clinical judgment whether we should decide we should go for erythropoietin or not. But if it's a cardiac surgery, if patient with anemia of chronic disease or inflammation undergoing cardiac surgery, the different society like ICTA, the Society of Cardiovascular Anesthesiologists, recommends the erythropoietin administration and concomitant IV iron for the patient if their HB is below 13 gram per deciliter, right? And for patient with anemia of chronic kidney disease, especially those receiving dialysis, they are already on erythropoietin. So they are the other indication for giving erythropoietin. And for patient in whom blood transfusion is not an option. So a lot of patients in whom they are not ready for the blood transfusion, like your Jehovah's Witness, etc. In them, we have to build up the HB and erythropoietin can be used. So these are the indications of erythropoietin. Okay, then preoperative autologous blood donation, one of the blood conservation technique. Now this is going out of practice. It's a blood conservation strategies in which patient's own blood is taken and conserved, that if the patient requires during intra period, it will be transfused to the patient. Now this preoperative autologous blood collection is causing a lot of wastage of the blood, and it is also predisposing the patient to anemia. So slowly it is going out of practice. So preoperative autologous blood donation. Now this is declining day by day. Now why it is declining? Because it causes the wastage of blood. So if patient is not transfused, it is thrown, it is not to be used for the other patient. It should be properly taken, conserved, and it should be labeled properly. All this requires a lot of cost, etc. So expensive and inconvenient. Now this predisposes to the increases the risk of anemia in the patient, and because of this anemia increases the risk of blood transfusion in the patient. So slowly it is declining. So this is how we manage anemia. Oral iron for iron deficiency anemia, but it needs several months, and depending upon how much time we can postpone the surgery, we choose the plan. If the surgery is semi-urgent and within 4 to 6 weeks we have to take the patient, we can go for IV iron preparation, which takes 4 to 6 weeks to replete the iron stores. And we can also go for erythropoietin supplementation along with the iron therapy if the anemia is of chronic inflammation, etc. Because there the bone marrow is suppressed, and erythropoietin may be very good in stimulating the bone marrow and increasing the red blood cells production. And erythropoietin should never be given alone. It should be given along with supplemental iron. Okay, so this is for the iron deficiency anemia. Now if the patient, so how do we manage? So seeing the flow chart,